Hi, everyone. We are so pleased to have you with us today, no matter if you have received the vaccine or not, whether you are hesitant or not, if you have concerns, or if you just feel frustrated and fatigued with the current situation. We're here to continue learning about vaccines and to keep asking the important questions to help us all recover from the pandemic. So I am going to welcome our first two speakers, Dr. Gommerman and Dr. Gingras. Dr. Gommerman is a professor at the University of Toronto and the lead of Pillar 1, Immunology and Vaccine Protection at CoVaRR-Net. She holds the Canada Research Chair in Tissue-Specific Immunity and brings a wealth of experience in adaptive immunity and vaccine protection to the CoVaRR-Net team. Dr. Gingras is a professor of molecular genetics at the University of Toronto, and she is the lead of Pillar 2, Functional Genomics and Structure Function of Variants of Concerns. She is a senior investigator at the Lunenfeld-Tannenbaum Research Institute, and she co-directs the Network Biology Collaborative Center. I will now pass it on to Dr. Gommerman and Dr. Gingras.
It's fantastic to be here, and what I'm going to begin doing is by just orienting you a little bit about how the immune response recognizes a virus like SARS-CoV-2, and then how it responds to vaccines that protect us against disease caused by SARS-CoV-2, the disease that we call COVID-19. So the human coronavirus structure, you've probably seen lots of cartoons of what this virus looks like. And what I want to really orient you to is this, this protein, which is sticking out on the surface of the virus called spike. And this protein is very important for the virus for getting into human host cells or host cells of other animal reservoirs. And using spike, the virus enters into airway cells, and then the virus accumulates and stimulates an immune response. And between this infection and the immune response, if it's not controlled, you can get a lot of pathology in your tissues. So the human receptor that's used by spike to enter into cells is called ACE2. And so it's very logical then if we target using vaccines and introduce this spike protein into our vaccine strategies, we can make antibodies as well as T cells and other immune components to really target this spike protein. And that will hopefully keep the virus from infecting us or making us sick. Of course, this has been a terrible virus for the world. And one of the reasons it's really spread quickly through the world is because it's contagious, obviously, and it can spread from person to person through airway droplets. And unfortunately, with this particular virus, there's a period where you don't even have any symptoms. So you could be spreading the virus from person to person and not even know it. So anything like talking and coughing and sneezing are ways to spread this virus around. And that's why, of course, we've been wearing masks and we've been practicing physical distancing. So what happens when the virus infects us? Well, as soon as the virus enters our system, it doesn't take very long for the immune system to know that something's wrong. And what happens first is that our innate immune system gets triggered. And this innate immune system is like an alarm bell that says to the immune system, there's something wrong, there's a foreign invader in your body. And this can make you feel quite sick. But the purpose for this is to then recruit other cells into the airway where the virus is infecting the cells that line your airway. So this is the innate immune response. It's not a particularly clever immune response, but it does get things going, it kicks things off. And it's actually triggered by the pathogen itself. After about 7 to 10 days, your adaptive immune system kicks in. And this is really divided roughly into two major arms of the immune system called T cells and B cells. T cells, in particular cytotoxic T cells, can recognize infected cells. So if this cell in your airway is infected with SARS-CoV-2, the cytotoxic T cell will understand that, will target it, and will directly kill it. But it won't kill this cell or this cell that are not infected with the virus. So it's a very specific way of getting rid of the virus, whereas your innate immune system just kind of goes crazy and it doesn't have that level of specificity. B cells make antibodies. You've probably heard a lot about antibodies in the news. And B cells make these antibodies that will recognize parts of the virus on the surface of the virus. And spike protein is a really good target for these antibodies for the reasons I told you before. And what these antibodies do is that they'll glom onto the virus, and that will prevent them from entering into these airway cells. Or it can also trigger other downstream events that will allow for the virus to be killed. So when you have an immune response, and I'm going to come back to this slide a few times because I think it's quite important. What happens is that, as I mentioned, initially, it takes about a week for your adaptive immune response to kick in. So during that week, the virus is actually, starting to take a foothold in your body. But thankfully, after about 7 to 10 days, this adaptive immune response kicks in, which is composed of T cells or B cells. And then once there's enough of them, very rapidly they expand. And you can imagine that if they divide every half a day or so, 12 to 24 hours, you can get a really quick expansion of these cells that occurs over the next week or two. And then that immune response contracts, and it has to contract because if it didn't, you would actually have no more room for any other immune cells. We call that the primary immune response. So it contracts. But if you notice, if you're looking carefully, the amount that the immune response contracts is always higher than what you started off with. And that's because these are memory cells that can be triggered really quickly. And indeed, if you have another viral exposure, these guys come in really quickly, like within a day or so, and you get this very strong secondary immune response to the virus. And during this period, because this expansion happens so quickly and these cells are so good at dealing with the virus, you may not even know that you're sick. And so this is what we call a memory response, and it's characterized by more antibodies, more B cells, more T cells, and these guys are really good at doing what they do. They've actually improved over time. So what vaccines do is, and we'll focus on viruses, is that vaccines against viruses basically trick your immune system, and it tells your immune system that there is a virus infection going on, even if there isn't. So it triggers that innate immune system, and then it teaches your adaptive immune system to learn what this virus looks like, to make memory B cells and memory T cells and antibodies, so that if the real virus comes along later, you're already protected and you can have that really quick memory response that I just told you about. And our experience so far with vaccinations is mostly towards these pathogens that are childhood diseases. And so as children, when they're born, in the first 5 years of life, they go through a number of different vaccine regimens to protect them against these illnesses that were so devastating before we had vaccines for them. And actually, I've been thinking about it. I'm not sure we've ever had a global rollout of a vaccine in the midst of a pandemic against a virus for which we have really no prior knowledge. Our immune systems have never seen before. So this has been quite a big learning experience for all of us, I think, learning how to do that in the context of a pandemic. And, it's really a proud time to be a scientist and to be a citizen, of course, because really together, scientists and companies and so on have come up with many different vaccine candidates and have put them through the pipeline. And this is updated as of a few days ago. About 5.8 billion doses of COVID-19 vaccines have been given across the earth. And that's really just a staggering accomplishment. So I'm going to focus a little bit on mRNA vaccines because I think this is something we've been studying in the lab, and a lot of Canadians have received these vaccines. So what happens is at first a person gets an intramuscular injection of the mRNA vaccine, and when they get that, a lipid nanoparticle, which is basically like a bubble of fat, which is surrounding the RNA that's encoding for the spike protein, is what you're getting in your arm. And so that goes into your muscles, and cells in your muscles, including myocytes, but also cells of the innate immune system that are really good at gathering up foreign particles, will gather up these lipid nanoparticles. And then once these lipid nanoparticles are inside of the innate immune cells, the RNA is translated into the spike protein. Now, I want to be extremely clear here that this is happening inside the cell, but not inside the nucleus. So this RNA never gets integrated into your genome. It's something that's floating around for a defined, not very long period of time in your cell, and then it gets degraded. But this spike protein gets made, and it is recognized by the immune system because it's foreign. It doesn't look like something the immune system has seen before. And because it's foreign, B cells and T cells start to learn to recognize it, and they get good at being able to make antibodies toward it, or to make these cytotoxic T cells that would kill a host cell infected with SARS-CoV-2 with the same kind of spike. And as you know, we have approved vaccines in Canada. They've gone through a very lengthy or very detailed analysis. It may seem like this was sped up, but really it's because of the tremendous amount of resources that were poured into the different phases of the clinical trials, as well as the research and development phase. And so as you go along this trajectory, more and more people get tested for the vaccine to ensure that it's safe. And the other thing that's examined is whether they're efficacious. And to do that, you really need many, many participants. And the first trials that were done about a year ago used in the order of 30,000 participants that got a vaccine versus 30,000 who got a placebo. And basically, when you do that, you then wait to see who gets COVID-19, and then you determine how good your vaccine is at protecting against COVID-19. And that's exactly what they did. And normally those trials take a long time, except that because you need to get enough people to catch those events. But because when those trials were held, there was a lot of viral spread going on, and particularly in the US, they were quickly able to get that data as it rolled in. And then after that, it's the data is then presented and independently reviewed in the States by the FDA and in Canada by Health Canada. And they look through all the data to make sure that this is a safe vaccine for everyone and that the effectiveness is going to be high. And these trials continue on even after approval, because we want to know how these vaccines will hold up, for example, against variants. And you'll hear about that in a minute. And in Canada, as you probably know, we have 4 different vaccines that have been approved. We don't really have much J&J in Canada, if at all, but certainly a lot of people have been getting the 2 doses of mRNA, whether it be Pfizer or Moderna, or 2 doses of AstraZeneca. And as you know, some people are getting combinations of those vaccines, and that seems to be working really well. So how good are these vaccines? And I want to really make this crystal clear that we have to get our terminology right. So vaccine efficacy is really about whether these vaccines prevent disease. So I want to compare here what's the difference between an infection versus disease. Infection is what happens when the virus enters your nose or your mouth and it infects those airway cells. And if you've been vaccinated, you might have enough immunity at that site, or if you've been infected before, that you would actually sterilize and prevent infection. But that's not what these vaccines were designed to do, because of, as I mentioned, you get the injection in your arm. And what we found in our lab is there's actually some immunity in the nose and the mouth, and we look at the saliva, and that's kind of a bonus. So that is having some impact on preventing infection. But really what these vaccines do is they prevent disease. So if the virus gets past that first barrier of what we call the mucosa in the nose or the mouth, then it can enter your body. And here the virus gets stopped in its tracks because we have antibodies in the blood, as well as immune cells that were trained to see that virus. And so those stealth fighters are going to be mobilized, and they're going to block COVID-19 disease. And just to show you how well that works, I didn't have a similar map of Canada, but the New York Times has done this really great job of looking at county by county how much vaccine is being taken up, and county by county how much COVID-19 disease those places are experiencing. And the lighter the color on this map here, the green map, the less vaccination there is in that county. And the darker the color over here, the dark red or the dark purple, is the rate of COVID-19. So this was taken just a couple days ago. And I want you to focus here on this area in Tennessee and in Kentucky where vaccine uptake is not so great. And you can see that that corresponds to an area where there's a lot of COVID-19. And I actually like how, well, I don't like, but I think this is best illustrated in Alaska, where you have this very low vaccine uptake in this county, as opposed to these other counties. And sure enough, that's where most of the COVID-19 is happening. So originally, when these trials were done, as I said, they were really designed to measure whether the vaccines prevent COVID-19. And so, as I said, in that phase 3 trial, what you do is you recruit a whole bunch of people and you wait and see whether the vaccine group will be protected against disease more than the placebo group. So if you measure the number of COVID cases, one would hope that the vaccine group would be down here, but the placebo group, would over time would show more disease burden. And actually, that's exactly what the data looked like. And that was really stunning back in November of 2020, where we saw this incredible efficacy, as much as 95% compared to placebo. So that was then. How about now? We're about a year later, a little less than a year later. And as you know, and you've heard, and you'll hear more, there have been variants that have been going around that have challenged and really put a stress test on these vaccines. And this is just recent data from Wednesday that was released by Moderna. And they looked at 300,000, more than 300,000 people who were vaccinated in California versus an equal number of people who were unvaccinated. And they matched them for age and sex. And what they found was that, of course, there was a much greater degree of protection against COVID-19 for the vaccinated people. And even though about 40% of the virus that was going around was Delta, they still saw about a greater than 90%, 95% level of protection against hospitalization and death. And I really am interested in this statistic here, which is that even infection, so the ability to detect the virus by PCR, those people had a pretty strong protection against infection. And I don't think we totally understand how that works. And as I said, the vaccines weren't originally designed to do that, but I think we can all agree that's a good thing. But the number of these breakthrough infections was lower in the people who were more recently vaccinated. And so people who were vaccinated, more towards the beginning of 2021 had a higher rate of breakthrough. And so that's why people have been talking about waning immunity. So is your immune response to COVID-19 vaccination waning? Well, I take issue with the word waning because I think there's an awful lot going on in our immune response after we've been vaccinated. So if we go back to that kinetics of what happens when you get infected with the virus, this secondary immune response is the memory response. But if you imagine that this is really the same as getting 2 doses of a vaccine, you get vaccinated here, your immune response contracts, and you get vaccinated here, and then it contracts again. And so that's absolutely normal. To see a decline in antibodies, for example, is completely normal. And that's what we would expect of the immune response. And I would prefer to call that contracting as opposed to waning. And there's a whole bunch of reasons for that, primarily because during the memory response, even though your antibodies are coming down and these other cell responses are coming down, some aspects of your antibody response are actually in the background. They're actually improving. And there's a lot of resources being devoted to keeping those memory cells happy, even some that go into our tissues so they can be ready to respond to the virus. So I like to think of this as memory, as an immune response contraction, not a waning. And this is recent data that was published at 7 months. And really the amount of memory was quite impressive post-vaccination. So, this is a practical webinar and we'll take your questions later. But if you're trying to think, okay, how does this translate into me wearing a mask? Well, if you've been vaccinated, that's great. Congratulations. if you are around someone who's immunocompromised or around unvaccinated people, there's still a chance that you might be able to transmit the virus because, as I said, the vaccines were really designed to block COVID-19, not to block infection. And so that's why we're still masking. But we do know that even with vaccination, there's good immunity. We know that the virus, if you do get a breakthrough infection, it doesn't last for as long in the upper respiratory tract. So there's good reasons to be vaccinated, not just for yourself, but for your community as well, especially those immunocompromised folks. So I'm going to hand it over to Anne-Claude. We were both funded by CIHR to do this, and she will now present.
All right, thank you very much, Jen. So again, so my role within CoVaRR-Net is really to think more about variants of the virus and what is the consequence of having a sequence variation. So if you go to the next slide, Jen. So I just want to bring to the table that the virus do mutate all the time, right? And they do that whenever they have a chance to grow. So a virus infects you, and then what it's going to try to do is more copy of itself so that it can infect other cells and eventually other people, right? So, and the way that things work is each of the viruses will contain their own genetic material, and that will direct the production of the viral protein. And this genetic material is going to be either DNA, the same that we use as a storage of genetic material, or in the case of SARS-CoV-2 and related viruses, a slightly different nucleic acid called RNA. And so the problem with the virus is, I mean, it's good for the virus, it's bad for us, is that every time the virus infects a cell and starts expressing its viral protein and then try to make copy of itself, it makes mistakes. And when it makes mistakes, sometimes the mistake end up as a new sequence of the viral protein. Most of the time, those new sequences don't really change the activity of the protein, don't do much to the virus, and they're essentially kind of a neutral change. Sometimes, actually quite often, those changes are bad for the virus. So that means that the virus will not be able to, the protein will not be able to fold properly or to exert its function. The virus is not going to be able to be excreted or infect cells. So that's really bad for the virus. And this is a dead end from the point of view of the virus, and that's good for the host. But there's some other pesky mutation that the virus acquires through making mistakes that translate into some of the viral protein that are actually better from the point of view of the virus, right? They confer to the virus some kind of competitive advantage, and that turns out to be actually bad for the host. And those competitive advantage can be anything. It can be being able to make more copies of itself faster so that it can generate a much higher viral load in your body. It can be that it is able to infect cells better. It can be that it evades the immune system better. So any number of mutations that the virus makes as part of its normal replication cycle may result in the accumulation of sequence variants that form mutants that can be problematic. Next. And so what really, really is important to keep in mind is that giving a virus a chance to replicate helps creating new variants. So the best thing that we can do to prevent the formation of new and more problematic variants is to decrease viral transmission. And that cannot be done just at the local level, right? Because we're working really in a global world where the virus has been traveling on and on and on after being introduced in a country. We've had waves of variants that have gone across around the world. So really, we need to control that globally. All right, just a bit of, again, like getting the wording right and getting the definition right. SARS-CoV-2 variant of interest and SARS-CoV-2 variants of concern. You've probably heard about that in the news, but I just want to step back to say, like, first, all sequence that differ from the original virus sequence, which was an isolate found in Wuhan at the end of 2019, are going to be called SARS coronavirus variants. And again, this is a very neutral term. all it means is it's different in sequence. And again, I told you in the previous slide that most of them are going to be fairly neutral as far as we can tell. Many of them are going to be even detrimental to the virus, but some of them might be those advantageous mutation for the virus. And those, the WHO has termed them variant of interest. And so what we mean by variant of interest, Jen, can you move forward, is essentially that these have been tested most of the time in a laboratory, and they confer to the virus itself. So when we isolate it from the nose or the throat of somebody that's infected, they behave differently than the parental strain. And sometimes that means that they will infect cells in culture better. Sometimes that means that they will be able to evade monoclonal antibody cocktails or antibodies that are present in the blood of people that have been vaccinated or infected with a prior strain. And so we need to keep an eye on those particular variant, and we call them variant of interest, to just highlight that these might be actually problematic. And that can be done at the level of the entire live variant that we have isolated, or when we start having a little bit more information saying that this position in a specific protein of SARS-CoV-2 tends to be associated with immune escape or increased viral entry. Then if we just sequence another variant that has those mutations, then it gets to be put on our radar, right? Because the likelihood of this particular new variant that we haven't characterized yet in the lab, that this variant also has some bad properties, actually pretty high. So we keep an eye on those. The other way that variants become variant of interest and added onto that list is if we've seen over and over that these sequences get identified across different countries or that they cause localized outbreak. And this really gets debated at the WHO weekly, probably actually daily. And just to see like which variants are being identified through DNA sequencing and RNA sequencing and, making it to those lists. Now, when all of that is said and done, and the variants of interest look like they are indeed very problematic, then the WHO renames them variant of concern or VOC. And that's what we've been talking a lot about in the media, right? So those have definitively been proven to do something bad. Most of the time, it's going to be an increase in transmissibility, and that's based on all the epidemiology status. We're going to talk about a particularly bad one today. And sometimes this increase in the type of consequences that it has to the patient. If it makes a patient much sicker for different reasons, if the clinical disease presentation is different, or if there is an escape from the immune system and other therapeutic measures. So those get called variant of concern. And right now, if you can move forward, there is 4 of them that have been designated variant of concern by the WHO. They're renamed recently as Alpha, Beta, Gamma, and Delta, which makes our life much easier compared to the original names that were given before, just based on the relationship to the parental strain. So just to give you a bit of a detail about that. So right now in Canada, Delta is really the dominant strain. And so as of August 15, 2021, 97% of all sequences of any viral strain that was isolated in Canada was actually Delta. And this is a big change because early in June, what really was contributing to a lot of the cases was Alpha still, and Alpha had done all of the contribution from the third wave, so the wave that happened here in Canada in the spring. And so this is that darker blue color, so if you can just click quickly, Jen. Perfect. And so you've seen like there's been a replacement. So what has accompanied that as well is all the other VOCs that were actually on our radar back in April, May, June are now essentially not circulating anymore. It is all Delta. So which means that the scientific community in general, not just in Canada, because that has also happened almost everywhere in the world, with the exception of South America that still has different variants circulating, is that really the fourth wave in Canada is dominated by Delta. So why is that? And so initially when Delta came about, so that was first isolated or identified in India in the spring, and people thought that maybe Delta would be more prevalent because it escaped the immune system. And it turns out to not be that. Really, the problem with Delta is it has a single mutation in its spike protein that Jen has talked about. And this mutation is a single amino acid change that replaces this amino acid called proline at a specific position, which is the 681st position in the sequence of the protein. And it replaced it with a histidine, which is actually positively charged. And what that does is that it really helps making the entire spike protein a better substrate, a better target for an enzyme that we all have in our cells that's called furin. And so when furin cleaves that spike protein at that particular site, it makes the production of the viral particles that are made in all of the infected cells much more efficient at infecting other cells. And so that really comes down to just like one single amino acid being mutated. It's actually interesting that alpha, that was a contributor to the wave 3 of the infection, also has a mutation at the same position, but a mutation to a different amino acid, also positively charged, but different from histidine. This is an arginine. And so we already had this position on our radar as scientists because we knew that this was what was making alpha so contagious compared to the original strain. So when we saw, as a scientific community, not me necessarily, when we saw that same amino acid mutated in Delta, we immediately knew that this was going to be a possible candidate to explain some of the spread. And in fact, what happened with Delta, even more so than with Alpha, is that you make so much virus when you get infected that not only more of your own cells get infected, but you're also much more likely to be able to infect others. So I just want to point out that this is the main problem that we know about with Delta, but there's still some unknowns. So there is some escape from antibody-mediated immunity with Delta, but this doesn't seem to be contributing very much to the spread. And in fact, some of the other variants of concern, including beta and gamma, are in fact escaping better than Delta. So really, this is not the main reason why we have this Delta wave. There are some reports that Delta could also have mutation that may increase how sick you get when you are infected with Delta, but considering that you also make so much more viruses, this is actually a little bit hard to untangle what is the chicken and what is the egg in this case. I mean, the reality is you get sicker in general if you get infected with Delta than if you had been infected with the original strain or even with Alpha. But the reason why this is not immediately clear. Next. All right. The big question, and Jen got to that a little bit, but I think this is data that's even clearer. Are the current vaccines working against Delta? And so just to make you reassured, the answer is yes. So I told you already 2 slides ago that Delta is 97% of all infections in Canada starting in about mid-August. So here what I'm showing you is a timeline from mid-August to now, to mid-September. And what we're looking at right now is normalized by percentage of people, the cases, the patient in the hospital and the patient in the ICU that are either unvaccinated, and this is the red line, or fully vaccinated, and this is the blue line. And very, very similar, you can move one, Jen, very similar to what Jen was showing you with those nice maps from the New York Times, the unvaccinated here really dominate per capita, ICU, hospitalization, and cases. And so again, like Jen had told you that the vaccines were designed to prevent hospitalization and therefore ICU admission. So we expected that. But again, there is massive effect even on getting cases, right? So getting an infection that can be detectable by PCR. And so there are some numbers here that Jen can bring up. So the numbers are, again, extremely similar to what Jennifer was showing previously. You have a drop of about 98% in ICU occupancy, 96% in disease severe enough to bring you to the hospital. And again, 86% decrease in even the likelihood of you getting diagnosed COVID infection. So bottom line is, indeed, the vaccines do work against Delta. So, and this is true across all provinces, across all of the data that we've seen in the world. So I attend the weekly WHO meeting, and this is still the case with all of the circulating variants today. And again, like we're talking about population level. So what happens at the individual level? And I see that in the comments that some people have are immunocompromised that are attending this seminar. So I just want to comment on that in the next slide. So this is at the population level, but of course, like we're being very careful about population that are more likely than others to have a weaker induction of immune response following vaccination. And this includes people that are on any kind of immunotherapy and immunosuppressive drugs, people that are taking cancer drugs, people that are very much older than the average population, and also just people that have a poor immune response in general. So we've been doing, and Jennifer has been doing as well, some studies in long care home, and we've been comparing resident versus staff using, again, in a test tube type of assay. We collect blood from these people, and then we challenge them with virus that are either from the parental strain or from strain derived from some of those variants. And here are so just 3 of them. We've, of course, done this since with Delta. And the only point that I want to make here, I don't want to go into any details. We look very, very carefully at the ability of the blood from a resident versus a staff to be able to prevent the entry of those viruses into cells and culture. And what we see, and you can see very clearly, is the resident, a lot of them are not able to prevent the entry, not only of the Wuhan strain, which was the original one, but particularly of some of those VOCs. So what that means is that even though we've just been looking at one facet of the immune system, we haven't looked in that study at T-cell response, but by and large, that means that at least for neutralizing antibodies, if there was a variant of concern of those particular type that would show up in that particular LTCH home, those residents would be quite vulnerable to it. And again, this emphasizes that, you know, what we can do to help them is, of course, for us to get vaccinated, but also to realize that even vaccinated, we still may be able to carry a small load of virus, and we may be able to infect these people. So we have to be quite careful around our most vulnerable people. But of course, if we get vaccinated, we decrease our own danger to them a lot. And this is just the text box in there. So again, this is what I'm saying. So at the population level, the vaccines were great. But if you are immunocompromised, or if, you know, for whatever reason, you're close to people that are, I think keeping your distance and being masking around them is really important. All right, so what about the future, right? So again, what I told you is the virus will keep mutating as long as it's allowed to replicate. So the best thing that we can do collectively around the world is to prevent the virus from replicating. So really trying to maintain public health measures, vaccinating people. You can move to the next 2 slide, really is gonna help. And so as scientists, what we're going to be doing is what we've been doing all along. That is, we're going to keep sequencing the virus, right? Because even though Delta is dominant now, additional mutation can be picked up and will be picked up on the back of Delta because it mutates all the time itself. And so we're going to keep sequencing those. It could be that a completely different strain comes and escapes vaccination. We don't know. And we're going to be continuing to study both the individual mutation as well as the variants themselves, again, using the same strategies that we've done before. And in light of that, there will be a revisiting of the public health measure consideration of boosters, including maybe some variant-specific booster. And the basic idea is that we want to be staying on top of that so that we don't get back to a situation where a lot of our population now becomes really sick, severely ill with this disease. And I think even though I understand that this is frustrating for the public to have those changing narrative, this is because the virus is moving fast, right? So we need to, be moving in sync with it, or hopefully ahead of it, so that we can essentially keep it down. And again, that's my last slide. As Jen, I'm funded by the CIHR as well. Thank you very much.
Thank you, Dr. Gommerman and Dr. Gingras. I think that was very important knowledge for us to have a fundamental science understanding of, the immune response and viral mutations and variants of concerns. I just want to remind our audience to ask questions in the Q&A button instead of in the chat, because we might not get to everything in the chat. And now I'd like to introduce Dr. Mohadrin, who is a professor of community health and epidemiology at the University of Saskatchewan, and he is a highly regarded academic leader in the field. His research focuses on social epidemiology, public health, population health intervention, maternal and child health, health in place, and community university research collaborations. He also leads the University of Saskatchewan project to continue Canada's work in Mozambique, focusing on maternal mortality and improving infant health. I'm going to pass it on to Dr. Muhajarine now.
Thanks, Emily. I thought that I was at my funeral. But thank you. All joking aside, it's wonderful to be here. And Jen and Anne-Claude, I learned a lot this past 40 minutes, and thank you for that. And a lot of things that I sort of knew was confirmed. Thank you. And we'll continue. I'll continue the story. But before that, I want to say that that I'm joining you from Saskatoon, Treaty 6 and Métis lands. And I settled here as an immigrant in 1990. So I'm from Sri Lanka originally. With that aside, then, I want to pick up this beautiful story that has been told by my colleagues Jen and Anne-Claude, and pick up from there and say, what happens to vaccines when it gets into people? What I mean by that, let me just go here first. So, can people see it? Emily, yeah, okay, good, yeah, so perfect. And so the first dose of vaccine in Canada was administered on December 14th in Quebec, and what happens to vaccines that is available at an individual, community, and a population level. And I want to very quickly then just focus on vaccine hesitancy. And a little bit of a definition here of vaccine hesitancy, and that is defined as a delay or acceptance of refusal of vaccine despite availability of vaccination services or vaccines, really, doses. And typically it is thought that there are three things, in fact, 5 things you'll see in the next slide, that influences people's reluctance in getting vaccines, even during COVID-19, which has disrupted our lives enormously. Complacency, convenience, and confidence. I'll go into these 3 a little bit more in the next slide. But an important thing to mention here that when you set aside people who will get a vaccine readily, when it is available, I mean, there's no questions asked, they've been actually waiting for a vaccine to be available. The rest of the folks, are really, they are in a continuum from kind of reluctant, delaying, want to wait and see, all the way to people who will absolutely not get a vaccine, no matter what happens, who tells them to get one, and so on. So that is a continuum. The data that we have sort of settled on in terms of Canadian general population, about 15 to 17% are in this group of people who are hesitating to get a vaccine, COVID-19 vaccine. And within this 15 to 17%, about 6 to 9% are in that extreme kind of end, of that vaccine hesitancy continuum. Those are the people who will refuse a vaccine. So, back to this heuristic, really, we kind of, conveniently refer to it as 5 C's that can help us understand, explain, and then perhaps surmount why some people are not getting their vaccine shots. Confidence, complacency, convenience, calculation, and collective. I'm not going to speak a whole lot on the last two, calculation and collective, but maybe say a couple of more things about confidence, complacency, and convenience. Confidence is really about the trust that people have on the vaccine itself, but also the authorities, government, pharmaceutical companies, health authorities in your province, in your regions, and even scientists, I would say, who are doing studies and generating information that helps in vaccine development. All of these people, the trust they have on these people to in getting vaccines, developing vaccines in a proper way, meaning, through trials, and the motivation, as well, behind this vaccine. So that is confidence, the trust that people have. Complacency is really about people feeling that their perception of risk for vaccine preventable disease are quite low. They don't really feel that vaccines are needed or necessary for not only for COVID-19, but for any other disease, childhood diseases as well. And as well as complacency is about feeling at this stage of the vaccine campaign in Canada, feeling like, well, maybe I could get by without getting the first shot or the second shot, because enough people around me have got the vaccine. So it's a little bit of a kind of being lazy, if I could put it that way, and a complacency there as well. Convenience is really about availability and accessibility of vaccines. And I think the convenience is the easiest to address. Complacency can also be addressed, with some effort and some strategic, targets and so on. But confidence, I think, is the most difficult, most intractable, and most challenging to address of these first 3 C's. So some numbers in terms of vaccine hesitancy. So it varies from province to province and territories. These are numbers that is based on fully vaccinated population of the total population in a province or territory. So, it is the whole population of a province or territory, and fully vaccinated, meaning 2 doses. So it ranges from 53% in Nunavut to 73% in Yukon, and across as of September 4th. And large majority, and I think this had already been mentioned, I think both Anne-Claude and Jen mentioned, about 88% of COVID-19 cases in Canada are among the unvaccinated population. 5.1 weren't protected by the vaccine yet, but meaning that enough time hasn't gone by since they have got the fully vaccinated 2 doses in order for that immunity levels to reach optimal level. And the secondary response, probably what Jen was talking about, 5.4 were partially vaccinated and 2% were fully vaccinated of the people who had COVID-19. So I'm going to show you some data that we have collected ourselves from Saskatchewan. This is population-based data that we started collecting in May 2020, May 4th, and specifically. The study is referred to as Social Contours and COVID-19 study. We post kind of ongoing data and results on our website, Sphere website. And And it's a longitudinal panel study of about 1,000 responses per month. So we have about over 10,000 responses over the 12 months. We actually took a little bit of a break in November, about 6 weeks. We did not collect data, and then we went back to collect data after that. 76% respondents indicated they had been or will be vaccinated. So this is starting in May 2020, when we did not have any vaccines, although continued to 21. So between May of 2020 to December of 2020, we were asking the question in a bit of a hypothetical way. If vaccines were available, will you get it? Some people said yes. Some people said don't know, not sure, and other people said no. So those are the three options. And the numbers that you see there are 76%, they will get a vaccine or have already got a vaccine after December last year, 13% not yet decided, and 11% stated they will not get vaccinated. And it is interesting to note that sometimes some people, some people said people who will get a vaccine might actually not wear a mask or social distance themselves because they'll feel protected. It's a displacement of behavior. So, they take a vaccine, they feel protected, and therefore they relax about other preventive and protective behavior. But that is not what we found in our data. We found exactly the opposite. A cluster of behavior that protects people against COVID-19 were taken by people at the same time, simultaneously. If you get vaccinated, you're also willing to wear a mask. You're also, social distance and so on, and the opposite of that as well. This is, again, time trends data. I'm going to move through fairly quickly here, because maybe some time left for discussion. This is only to say how there's a little bit of a journey, that people take in their readiness for vaccine, starting last May to this May in 2021. And I think this reflects few things in their, in their surrounding, in the province, in the context, of COVID-19. Is COVID-19 having surges? Is it very intense, as it is now in Saskatchewan with Delta variant? And also what people are exposed to in the development process of vaccines, the trial results and etc. back in the summer last year and in the fall. We saw some of the lowest percentages of people saying that they will get a vaccine in sort of September, when there were a lot of questions about vaccine development coming in the media, particularly, focusing on the Sputnik vaccine in Russia and so on. So I guess the point here is that people are exquisitely oriented to learning about what is happening in their surrounding, in the media and so on, and they respond to it, to some extent. This is a table that presents who are vaccine hesitant and those who are refusing vaccines. Again, this is Saskatchewan data in the past year. We are seeing that women, are more likely to be hesitant compared to men. People who are financially less secure have less education. Newcomers, who are settled within the last 20 years, more hesitant or refuse. Indigenous respondents, and also people who are not practicing, protective behavior, like not wearing masks, do not consistently practice social distancing, as well as perceptual variables, like people who are not very concerned about spreading the virus in the community, people who believe that that COVID-19 is not a big threat. So these factors are positively related to hesitance and refusal, and these factors, the last four, are negatively related, so less likely to be hesitant or refusal. If you report your health is generally excellent or very good versus fair or poor, you are less likely to be hesitant or hesitant. if you believe you'll get a mild or moderate or very sick from COVID-19. So personal risk, with COVID, you are less likely to be hesitant or refusal and so on. Probably this doesn't come as a big surprise. And these factors has been consistently shown in other studies as well, not only in Saskatchewan. There's great geographical variability and variation of vaccine uptake. In Canada, in Saskatchewan, no different here. And I'll just go back there. And what is interesting is that I'm not showing it here. There is almost a correlation that Jen showed for US. There's county level data, geographical data with fully vaccinated people versus COVID-19. We see the same thing in Saskatchewan. And when we correlate this with the COVID-19 case rates. So, different provinces and territories has taken different approaches to addressing vaccine hesitancy. These could be kind of classified to these 5 types of things that people have, governments have done: financial and material incentives, lotteries, and I actually think these have not been very successful. There's a recent article that compares Alberta's lottery versus BC's vaccine passports, for example, in encouraging vaccine uptake. Media and social media campaigns, like I said, vaccine documentation and passports, all the provinces except for one, I think right now, as of this week, as of 2 days ago, Saskatchewan introduced this on Thursday, and have some kind of a proof of vaccine documents or certificates for doing things, outside the home, or working, returning to work, or returning to study in universities. Increasing availability and accessibility of vaccines, mobile clinics, pop-up clinics, etc., and drive-throughs and so on, and community outreach efforts. From sort of having neighborhood block parties that is around a vaccine theme, all the way to fairly organized community outreach efforts using influencers and community champions at a local level. A lot of these frameworks developed for addressing hesitancy have not been evaluated for effectiveness. I think we just haven't had enough time, I think, to evaluate this. This is something that we have to do. And also the second point, I think Kimberly will be talking more about this in her remarks. And data on effectiveness of vaccine documentation and uptake should be collected, implementing vaccine passport programs in different settings. I just saw some data from University of Saskatchewan that has passed policy for requiring vaccine documentation. As of this last Thursday, 91% of people who responded to university faculty, staff, and students have indicated that they are vaccinated. Only about 3% have indicated they are not vaccinated. So they will have to show negative test results in order to enter the campus. 3 slides on recommendations. So what do we do about vaccine hesitancy? We have recommendations at the national level. This is really sort of directed to more research and evaluation to understand with all the strategies that we have for surmounting vaccine hesitancy has really kind of produced results. In terms of provincial recommendations, I think I already mentioned mandating vaccine certification. This is quite controversial. I think, I have referred to this as a carrot and a stick approach. Carrot in terms of people who want discretionary, choices to go to a restaurant, to go to a gym, need to show that they are fully vaccinated, or people who work in those businesses, or people who work in the healthcare system, in hospitals, or in universities have to show that they are also protected, as well. So that is the stick part of the carrot and stick, I think. Continuing professional education, there's actually a lower level of vaccine uptake among healthcare workers, very surprisingly, in fact, shockingly, than we see sometimes in general population. And we need to train and educate provincial health workers about Canada's colonial roots and so on, which Kimberly will get to. And the last slide here, in terms of regional and local recommendations, for public health professionals, we have to be very creative in terms of reaching people who are vaccine hesitancy. We have to have strategies around engaging community leaders and really getting the message out to people in very creative ways. And for clinicians to really incorporate their consultations with their patients around vaccine, uptake as well, motivational interviewing, strategies and so on. And also the last point, but not least here, that medical professionals who might have an affinity, who might have trust among people who are equity seeking. So those who are minority groups, could engage on one with family in order to motivate, encourage people to get vaccines. I think I'm going to stop there and pass it on to Kimberly.
Thank you, Dr. Muhajarine, for illustrating the scope and complexity of the problem of vaccine hesitancy. I'm now going to introduce Dr. Huyser, who is an associate professor in the Department of Sociology at UBC. She oversees the Indigenous engagement, development, and research pillar at CoVaRR-Net, and her research contributes to our understanding of social determinants of health problems faced by Indigenous peoples, and how it furthers our comprehension of social mechanisms that undergird population health.
Thank you, Emily, and thank you to my esteemed panelists for this great discussion so far. We'll continue with the discussion, but on looking at Indigenous peoples specifically and on vaccination for COVID in Canada, but also I'll make some mention to the US as well. Before I do that, I want to acknowledge my other team members of CEDAR, Dr. Michelle Johnson-Jennings, Dr. Catherine Collins, and then also Tracy Christensen, who really kind of helps everything go forward, and thank her for today for keeping the logistics of today going forward as well. I also would like to quickly introduce myself as a Navajo woman. Ashihi Nishle, Bilagana Bashichin, Sena Bithni Dashiche, Bilagana Dashidnala, Akwitego Dinet Azana Nishle. This is for my Indigenous relatives as well as my Dinet relatives so that we know how we relate. In English, I am of the Salt People clan, and I'll just do the summary of that. The rest of it, Navajo is matrilineal, and so my mother's clan is my clan, and so that's my first clan, my primary clan of the Salt People. So today we'll be talking about Indigenous peoples. I'm going to give you an overview of what we know, particularly around hesitancy. So when it comes to Indigenous peoples and the vaccine rollout, specifically in British Columbia, but this happened across Canada and also in the US in many ways, but I'll speak specifically the terms of British Columbia. Indigenous people were considered higher priority for receiving the vaccine, so we saw the vaccine roll out earlier. And this decision was really informed by the National Advisory Committee on Immunization. Because of what we knew about COVID-19 is that it affects racialized and marginalized populations disproportionately. And so this preventative effort for vaccines, it was important that these groups receive first. Also, we know from broad literature on health and social determinants, systemic barriers such as poverty, systemic racism, and homelessness also increases the likelihood of exposure and infection of COVID-19. Also, the risk of transmission is also especially high in remote and isolated First Nation communities. And this is also true for the US as well, where physical distancing and other infection prevention control measures can be challenging. Because in these communities, we often see a couple things of multi-generational households, but also infrastructurally many First Nation communities in the US and in Canada do not have access to clean water. And so that makes it difficult then to do the mitigating preventive behaviors of washing one's hands. So furthermore, adults living in First Nations, Métis, and Inuit communities also have limited access to healthcare, having to do with long distancing, but also just the structure in which healthcare is set up in the US and in Canada. So this slide just gives you a sense of what the rollout has looked like over the past year or so. And as of earlier this week, September 14, there are 687 communities in Canada with vaccinations underway, and this includes First Nations and Inuit communities in both province communities and in territories. So this, over time, this blue line with the red dots is the number of active cases in First Nation communities, and the bars, the gray bars, are those of cumulative number of vaccine doses that have been administered. It includes first and second doses. And as you can see, we have across nationally in Canada, in First Nation communities, there is some association between the more doses of COVID-19, the active cases are going down, like, overall. And what we learned from the earlier presentations, you have a sense of what the science and the biology of that is, how that is happening, that now that we see that at the social public health level. Now, the vaccine rate in Indigenous populations, I have some kind of old numbers, I couldn't find any from this fall, but Indigenous people who received the first dose in Canada in March was about 51%, and then 39% in the US. And now in British Columbia in particular, this summer in July, BC overall, of everyone who is eligible, the rate of having the first dose was at 81%, and it was only at 64% for First Nations peoples. Now this is particularly First Nation status people that were part of the healthcare system. So that is reflective of that particular number. So with that, it makes us understand or get a sense of what vaccine hesitancy may look like among Indigenous peoples. Nazeem in the previous conversation mentioned it as well. But there is also some things about some variation by location, both in terms of country as well as where folks live in the country. Indigenous peoples in Canada are more likely to be vaccinated than their relatives in the United States. And this work has been done by COVID Impacts, which is another COVID network funded by CIHR. There's also some interesting differences by location, particular reserve versus off reserve. So Indigenous peoples in the US who live on reserve are much more likely to get vaccinated than Indigenous peoples on reserve in Canada. But Indigenous peoples living off reserve in Canada are more likely to be vaccinated than Indigenous peoples living off reserve in the United States. So this, I think, speaks to some of the ways in which healthcare system delivery rollout, as well as community involvement, speaks to how the percentage of vaccine corresponds to where people live. Now, of the people who in the survey done by COVID Impacts said that they were vaccine hesitant, and these are all folks who identify as Indigenous in the United States and Canada, here are some of the reasons why they said that they were hesitant. In the US, we have the blue bars, and in Canada, in the green. The overwhelming response was it's too rushed or they're worried about side effects. And hopefully through this webinar yourself, if this is some of your concern, especially it being too rushed, hopefully Dr. Gommerman's presentation helped address some of those concerns. But also there's some misinformation, right? Misinformation is a little higher of a concern in Canada than in the United States, as well as trust. And this is trust both in terms of the vaccine itself, but also of a healthcare system as well. There's also political reasons where people are hesitant, personal preference, and religious reasons as well. So you can see there's some variation across why people have reported being hesitant, but overall there's concerns about how quickly the science has developed. But hopefully through the presentations today, you can understand the science developed quickly because it was really ready to be developed quickly based on earlier science. Some of the things that seems to have really worked in overcoming vaccine hesitancy in Indigenous communities has been Indigenous community-led education and vaccine effort events. So for example, we've seen Facebook Live meetings with Indigenous leaders and medical experts to answer questions about vaccine education, to dispel myths, to provide toolkits and resources. Just of 2 examples out of thousands of communities, Manitoba First Nations pandemic response team met with their Grand Chief and had conversations with medical experts to really address the concerns that were being voiced by the community. Also, the Navajo Nation, the Indigenous community that I am from in Arizona in the US, President Jonathan Nez did a very similar thing where every week there was a weekly live meeting giving update of the status of the virus as well as answering questions. If you all were unaware, in March, April of 2021, or 2020, excuse me, 2020, the Navajo Nation had the highest per capita rate of COVID-19 in the US country. And so his efforts, the nation's efforts to really address this has been a whole community event. The second big thing, so these regular communication between Indigenous leaders and medical experts have really helped, as well as community-wide vaccination events where the community as a whole goes for their first or second dose. And so together in a collective effort, we saw this particularly in Indigenous communities across British Columbia, where the community, the whole South turned up at one date to get vaccinated together. So really these recommendations continue to move forward is to continue to support and fund the work of community-led education efforts and immunization events, and also to work toward for healthcare workers and medical professionals, before working with Indigenous communities, it's important that they become knowledgeable about and work to address Indigenous specific racism in the healthcare system. For British Columbia, there is a report that you can read called In Plain Sight, where it really talks about the details of systemic racism within BC healthcare. But overall, as far as addressing community health, and particularly for Indigenous health, whether it's for COVID-19 or any other upcoming illnesses or viruses or diseases, we really need to end systemic barriers such as poverty, Indigenous specific racism, and homelessness, because the lack of these resources and this discrimination really limits the ways in which communities and individuals can access and protect themselves. Lastly, we really need to build infrastructure for First Nation, Métis, and Inuit communities, particularly for healthcare, but also basic infrastructure, including clean water, to all of our communities as well, because clean and safe environment is essential for our health as well. So I will hand this back over to Emily for our question and answers time.
Thank you, Dr. Huyser, and thank you to all of our presenters. I learned a lot more about both, the scientific and immunology aspects, but also the public health challenges that we have with vaccine hesitancy. So recently, the UBC Vaccine Literacy Club has been hosting these workshops for youth locally in Vancouver about vaccines, and a lot of youth are very curious and interested, and we have some burning questions that we would like to ask these researchers. So one of the questions that have come up is that some people have an irrational fear of needles. So are there any other developments of vaccines that are not in the form of needles? For example, something you can breathe in, something you can take as a pill with food, or some other type of less intimidating vaccine?
I think I'll answer that. So there's been some development of what we call nasal mist delivery for vaccines. The primary reason for developing this is to really elicit a good immune response at the mucosal surface in the nose and the mouth. However, having said that, we know that even delivery of vaccines in the arm still can elicit some immunity at that surface. And there's certainly some protection against infection from the vaccines that we have at the moment that are delivered in the arm. But a nasal mist is, I think, a great idea. There are some technological hurdles, I think, and delivery hurdles that will need to be surpassed, and making sure everyone gets the correct dose and so on. But it's an active area of research, yes.
Thank you, Dr. Gommerman. And we know that there are various types of vaccines that are being developed. And I know you touched on this earlier in your presentation as well, detailing how the mRNA vaccine works. And it is a huge accomplishment, the mRNA vaccine. Could you talk a little bit more about the differences between a viral vector-based vaccine and an mRNA vaccine?
You're asking me?
Yes.
Okay, sure. So the other vaccines that are not mRNA based that you're likely most familiar with are the J&J and the AstraZeneca vaccines, which use a virus called adenovirus, which is really harmless to humans. And what's done is that the genetic material of the adenovirus is removed and replaced with, so the virus is sort of gutted and replaced with the DNA that would encode spike. And so in this case, instead of an mRNA delivery system, it's a DNA delivery system. But at the end of the day, it's the same consequence. So the person gets a dose of the spike, which will get encoded and made into a protein. So at the end of the day, whether you get the adenovirus or the mRNA, you're still getting a dose of spike to teach your immune system. Just the delivery mechanism is a little bit different.
And another question that came up in our workshops is that in 1980s, we declared smallpox eradicated. And since then, there has been no other cases of naturally occurring smallpox. So why can't we eradicate other diseases as we did with smallpox? And anyone can just answer this question.
That's a big question, Emily. And, just to if there's one or two cases of natural occurring smallpox, that'll be an epidemic. Because that's it has been eradicated, and so when we talk about epidemics and pandemics, it's all compared to some baseline, some reference point. So having said that, the campaign to eradicate smallpox. Mostly led by Dr. Henderson, who was from public health school in Johns Hopkins in the 80s, 70s, and 80s. That's a huge success story. Why can we eradicate other diseases like that? It takes a lot of effort. It has to be a global effort. We have to go to all of the places, all of the communities, rural, remote, urban, everywhere in this globe where there is a case, or there might be cases, people who are susceptible to a disease, and we have to inoculate them. So this is no small feat at a global level. And the third thing I will just say is that, that's why we haven't eradicated a whole lot of, diseases. But also viruses live in reservoirs, animal reservoirs, so not only just in humans, and I think that was alluded to a number of times, and what is happening is with human and animal habitats colliding, there's more opportunity for virus to jump species, right? So that is always there's always that chance and opportunity for diseases to continue. And I think the last thing I would say is that, and Jen talked about this, I haven't seen that number, Jen, not recently, that how many billions of doses have been administered already? About 7
Yeah, almost 6
billion.
billion.
Almost 6 billion. So these are doses, not people, just is an important difference. And I think when we, that's a huge number. That's a huge number of, doses already in people's arms. And we have never done anything like this in such a short time that we know of, so that's amazing achievement, just to say that. Maybe others want to jump in.
Yeah, that is quite a significant accomplishment so far. And the pandemic probably, from what I understand, won't end until the majority of the population on Earth gets vaccinated. So when do you think will the pandemic end? At what point? And will we ever have another pandemic? And perhaps how can we be prepared for the next pandemic that comes up?
Maybe I'll start. I think, will we have another pandemic? I think the answer is going to be yes. The question is when, and are we going to have learned from all the mistakes that collectively as a planet we've done during this particular pandemic, right? So I mean, there's going to be still zoonotic transmission. So that means transfer of virus from animal reservoir to a human host. That's going to continue, right? The question is like, will we be able to identify them soon enough and act appropriately, right? So there was a lot of warning sign with SARS-CoV-2 based on our previous experience with SARS-1, with MERS and so on, that, maybe it was not taken seriously soon enough and was not nipped in the bud, right? It could have been much easier. It would have been much easier at that not spread around, right? Because, we would never be in the situation where we are right now. So again, like, I think the fact that we have transmission from animals to human will keep happening. And the question is like, how soon will it be that we encounter something again? Maybe it's going to be 20 years, maybe 50, maybe 2, right? We don't know. And I think what's important is to keep, aware of that and make sure that the communication are kept open. And so the more you communicate clearly, nationally, but internationally as well, about any kind of emerging threat, the faster we can react. And again, like, this is a global game, right? It's not, by British Columbia being perfect at their threat awareness thing is not going to do it alone, right? We need to be doing that at a global level. And, frankly, like, Canada is a rich country, right? Some countries don't have quite the facilities and all of the resources that we have. And we have to, be aware of that and also be a bit caring about the population as a whole in Canada. And I saw one of the comments in the question about, vaccine inequity, and that's a big problem, right? So of course we could vaccinate with a third dose all the population in Canada. The question is, should we, right? And I think, as Jen as kind of indicated, like, with the exception of people that are immunocompromised or in LTCH, the answer is probably not, right? Because we need to share and we need to help maintain vaccine equity across the planet and not just within the country.
Can I just say, Emily, I think the more appropriate question is whether there will be another pandemic, but whether we'll be prepared for the next pandemic. I mean, that really is the question I think that we need to answer right now, as well as in another year, another 2 years, when we are at a different place with this particular pandemic. Are we ready? Are we prepared? Not just only in Canada, but globally, are we prepared with our institutions, it's our infrastructure, just readiness, just people's attitude and behavior? Are we prepared to face when that next pandemic happens or the next epidemic happens? And I think that is a great question. So.
Yeah, and I'll pick up from that as well on the preparedness. Is also, as a sociologist and demographer, that as we look over the history of illness and disease, we can learn what the social factors are that really help facilitate spread, right? Because there's different things that we know facilitate spread of many contagious infectious diseases, regardless of how it happens. And we know the systemic barriers are the things that really facilitate it, right? Like the lack of access to resources in a number of different ways, as well as communities and peoples who are marginalized, so kind of excluded from our society, become particularly vulnerable. And so those are things that I think as a society hopefully learn, both at a province and a country and a global level, of ways for us to share resources so that there are fewer people vulnerable to infection, whatever that infection may be. And so increasing access to resources, access to clean food, water, is incredibly important.
And also in a course that I've taken, we talked about, how deforestation really contributes to these things, because we have more interactions with animals and human hosts and increases the likelihood of these things happening. And with climate change and warming temperatures, there are things that we need to be prepared for, to have a faster response, to have more communication, and to share these resources so that we are prepared. So going back to more of an individual level rather than a global level, there's someone who's asking that, there are people who say, I don't know what is in the vaccine, I don't want to put in my body. So is there really any ingredient in the vaccine that are things we don't ingest from other sources, such as food or common medications? Are there really any ingredients that are considered foreign and can trigger responses in our human bodies?
Well, I mean, let me just start by saying that the whole point of a vaccination is to introduce a small piece, or let's just focus on a small piece, because there's different strategies. But in this case, a small piece of a pathogen, in this case a virus, that on its own isn't going to be able to harm you, and so that has to be foreign in order to generate an immune response. If it were not foreign, your body would ignore it. So that's the whole principle of the vaccination approach. To get that into our body efficiently, as I said in my slides, the mRNA is packaged inside a lipid nanoparticles. That's basically some fat that makes a little fat bubble so that it can slide through into a host cell. And I believe that there is some PEG in the vaccines, that's polyethylene glycol, which is something that is a component of many laxatives, for example, but it's an inert compound which you would receive extremely low amounts of. So there's nothing in those vaccines that we need to be concerned about that would irritate us. I know that people with PEG allergies or other kinds of allergies have concerns about taking the vaccine. And for those people, I would encourage them to speak to their doctor and to have the vaccine in a supervised setting so that we can make sure that there's no allergic reactions. But when we look at the range of adverse events that have been documented with these vaccines, they are extremely safe, and the adverse events are extremely rare. Contrast that, of course, with COVID, where you are taking a risk of damage to your internal organs, long COVID, etc. The risk-benefit analysis, which I think as humans we find hard to do, right? As a parent, when I brought my kids in to be vaccinated when they were babies, as an immunologist, I knew exactly that this was the right thing to do. But as a mom, when I watched a needle go into my baby, there's a certain part of my lizard brain that said, right? And that's normal. It's normal to feel that way, but we have to use our rational brain and look at the risk-benefit analysis and ask ourselves if, this is a very safe vaccine that's saved lives, many, many lives, and is extremely safe. So I'm not a psychologist, but that's the analogy I sometimes give as a parent.
You know, Emily, last Sunday I had a conversation with someone who is a physiotherapist working in Alberta. You know, it's a son of a friend of my wife's who doesn't want to get a vaccine. You know, he's a physiotherapist. He reads the literature. He's actually very well educated, you know, and very well trained, and works with patients in his own way. But he's actually ready to leave his job if there is some kind of, you know, proof of documentation is put in place. He's actually ready to give up his work and move back to Saskatoon, you know, before he'll take a vaccine. So had a conversation, you know, and I think we have to engage one-on-one. We have to understand why people are hesitating. The fear of needles. I mean, I know few people who have fear of needles, and you know, so that's a good question. Are there other delivery modalities than through a needle? And you know, and I think we have to listen, and engage with people who have questions and issues with vaccines, you know, etc. So this person I talked to, he was telling me that the control arm of some of the clinical trials in phase 3 were terminated before some of the endpoints were reached. So he got this information from somewhere, you know, and he was asking, is that the case, and etc. So very detailed questions, you know, like that some people have, you know, people have very detailed, very specific questions they came across somewhere, read, you know, either social media or in regular media, and they have formed opinion, you know, around that. And they need to get past that, get over that. And so that kind, gentle engagement with people on neutral terms is a much better way to you know, to kind of counter you know, and encourage people to think about getting vaccines who don't want to get vaccines, than just trying to shove it down their throat. I mean, just to put it that way.
Thank you. And thank you to all of our panelists today, Dr. Gommerman, Dr. Gingras, Dr. Mohadrin, and Dr. Huyser. Thank you, Tracy, for supporting the administration. And I just want to say thank you to everyone here for attending our event today. I think we really had a fantastic conversation, and I certainly learned a lot of details today. And I hope everyone has just come away more inspired by the sheer amount of science and the amount of accomplishment we have achieved so far, and found a peace of mind as we keep combating COVID-19. I hope you learned something, and I hope we debunked some questions, and I hope that we can extend this conversation with our friends and our families, and to help us all recover from this pandemic. If you would like to learn more about what the UBC Vaccine Literacy Club is doing, you can follow us on Instagram, or if you are a student, you can learn more about us there as well. And I encourage you to follow up with the ongoing work with the CoVaRR-Net as well. Dr. Gingras?
Yeah, thank you very much, Emily, for organizing that. And I know I have been answering some of the questions by typing in the chat, and I know Jen has done that too. So maybe if you don't shut down the meeting right now, the people can look back at their question that we've tried to answer, and I'll try to answer a few more for the next couple of minutes. But thank you very much to you for the organization.
I will too. So Emily, if you can keep the Zoom open, that would be great.
Fantastic.
Thank you, Emily. Fantastic.
Thank you, everybody.
Thank you, Emily. Thank you, CoVaRR-Net, for joining us today.